we'll get started then. Hi, everyone. I'd like to welcome you to our July webinar. My name is Kathy Nickham. I'm the Education Director for the DPC Education Center. And today we are privileged to have Dr. Keith Melancon with us. Before I introduce him, I'd like to just go over a couple of housekeeping things with you. Next slide, please. All of your lines are muted, and at the end, we'll have some time for question and answers. And at that point, you can unmute your phone by doing #6 and then mute it again by doing *6. You can also put questions in the chat room if you like. The recording and the slides will be available on the website in a short and timely manner. And we have a feedback form that will come up at the end of the program, and we hope that you'll fill that out for us to give us feedback and give us your suggestions for future things. Okay, next slide. I am pleased to introduce Dr. Keith Melancon to you. He is the Director of the George Washington Transplant Institute and the Medical Director of the Ron and Joy Paul Kidney Center at George Washington University Medical School. He is a professor of surgery whose specialties include kidney, pancreas, and liver transplantation, as well as laparoscopic kidney donor nephrectomy. His research interests have centered upon increasing access to health care for minority patients, particularly in the field of organ transplantation. He has spent his career trying to improve outcomes for the hardest to transplant patients, and thus he has been an advocate for ABO-incompatible organ transplantation, paired kidney exchanges, and immune system desensitization strategies. Recently, he and his team were the first ever to perform a fully ABO-incompatible deceased donor kidney transplantation, as well as a fully ABO-incompatible living donor kidney transplant in an individual with an HIV infection. He hopes that with novel immunosuppression protocols that organ transplants will begin to last for the lifetime of the patient and that true transplant tolerance can be achieved in the near future. And at this point, Dr. Melancon, I'll turn the program over to you so you can help us learn more about the nuts and bolts of becoming a transplant patient.
Well, thank you so much. I'm very excited to speak to you guys today because I do think that it's important that people learn more about transplantation, particularly people on dialysis, because it is such a problem in this country. I titled my talk Transplant 101 because I want to give you the basics. I want to deal with some of the myths and hopefully enlighten people to this big problem in our country, which is kidney disease. The first slide here, you see that this is a picture of a chimera from Greek mythology, and the chimera is the symbol for the transplant surgical organization here in America. And it's our symbol because to be chimeric means to have different sorts of tissues. And all transplant patients have different sorts of tissues. I want to start with asking some questions because, you know, I am a professor, so I want to teach medical students a lot. And I always like to start with questions because in getting the answers over the course of the talk, we will learn a lot. So what is the most common cause of kidney disease? Stab injury, diabetes, hypertension, infection, or congenital problems. And I think that some people, they are surprised to learn that diabetes has become the #1 cause of kidney disease in this country. Which of the following contributes to the greatest possibility of developing kidney disease? I have on here a word, epigenetics, that some people may not be familiar with, but epigenetics really means, at least I believe, it means culture. What you eat, what you drink, how you exercise, what's done in your community. That's really what epigenetics are all about. Ethnicity, drugs, old age. The right answer is actually epigenetics. What you eat and drink and the way you behave is the #1 reason why people have kidney disease. What is the most effective way to control high blood pressure? Medication, exercise to lose weight, or diet? All of these are actually really good ways to control blood pressure, but people are surprised to know that your diet is really the best way to make sure that your blood pressure is no longer high. What is the most common cause of self-induced kidney disease? The key point here is self-induced. Is it IV drugs, non-steroidals, like over-the-counter medicines like ibuprofen, or is it accidents? And I can tell you, a lot of people are surprised to learn that non-steroidal medicines, over-the-counter medicines like ibuprofen, are actually the number one reason why people have kidney disease due to medication. And what is the most common type of diabetes? There are two types, type 1 and type 2. I always want to understand that type 2 is the most common cause, and it is very much linked to obesity. So being overweight is the main reason why people are diabetic. And I already told you that's the number one reason why people have kidney disease. When you look at an atlas of where kidney disease is in this country, you can see that the highest prevalence is in the south, the southeast. And the reason that is because of what I said earlier, which is that culture is the main reason why people have kidney disease. Too much salt and sugar in the diet, too much obesity. That's why we have so much kidney disease in the south. What are the most important causes of kidney disease? Well, I already told you, diabetes, high blood pressure, obesity. When you go into diagnosis, the main problems are diabetes and high blood pressure, as well as obesity. This is an epidemic in this country, and it's why the rate of kidney disease has increased. And when I talk about epigenetics, really what I'm talking about is the proteins that's made in your body. It comes from the DNA, but to think about DNA versus proteins, you have to understand that what is happening is your body will make a copy of DNA based on the foods that you eat and the exercise and your behaviors. So you and your identical twin could have the same genetics, but your epigenetics will change because of behavior. And you can ask me questions at the end, but that's what epigenetics means. So what are the symptoms of kidney disease? Well, unfortunately, lots of people that have kidney disease don't know it until they go to the emergency room and find out that way. But usually what happens is the blood pressure gets really, really high to the point of causing a bad headache. People start to have swelling, which makes their legs swollen or could even exhibit as trouble breathing. Proteinuria, and the main thing with proteinuria, meaning protein in your urine, is that when you go to the restroom and you urinate, you see lots of foam, i.e. foamy urine. That's a sign of bad kidney disease. Also, fatigue, or you start to get exhausted very easily. These are all signs of kidney disease. What is end-stage renal disease? So there are 5 stages to kidney disease. And I think one of the most important things for people to learn is that the first 3 of those 5 stages are actually reversible. So if you have kidney disease because you have high blood pressure and you're developing chronic kidney disease, if you get your high blood pressure treated and it goes into the normal range, then you can reverse your kidney disease. It's only at the end, stages 4 and 5, that you have what's called end-stage kidney disease. There is no comeback from that. That's when you start dialysis. So when you start talking about transplant, there are over 100,000 people that are currently waiting for a kidney transplant. We only do about 15,000 per year because there are just not enough donors. So most of the people that need a transplant find it difficult because it's hard to find enough donors for transplantation. Now, what I'm showing you here, these are deceased donors, meaning people that have died. But even if you add in being able to find a live donor, we still do less than 20,000 transplants per year. And like I said, there are over 100,000 people waiting. Thousands of people are added to the wait list every day. So what do people need to do to make themselves healthier? And this is pre-transplant as well as post-transplant. People need to latch on to this idea of how do you improve your health. And if you have end-stage renal disease, then the best way to improve your health is to be transplanted with a kidney. Well, that's easier said than done because you have to be in a pretty good state of health other than having kidney disease to qualify to get a transplant. So what's the path to transplantation? Well, the first thing is you need to be referred, or you need to refer yourself to a transplant program. Once you're referred, either your doctor refers you or you call up a transplant center and make an appointment, you then have to come in and meet with the team and have what's called an evaluation. Once you have the evaluation, the doctors will order lots of tests, blood tests, as well as diagnostic tests like testing your heart and your blood vessels and so on and so forth. All of these tests need to be done, and they need to be completed within a timely fashion. After you get the tests done, then you are presented at what's called a listing meeting. At this meeting, your case is going to be discussed, and an action will occur. And the action could be that you are listed, which is the best news possible, which means you've been cleared to undergo transplant. You could be deferred, meaning that more of the data needs to come back before the team could make an informed decision about your case. Or you could be denied. And unfortunately, many people that have kidney disease are not going to be in good enough condition to be able to undergo a transplantation, and they are denied. Once you are listed, that's not the end of the road, however. What needs to occur is every month your blood needs to be sent to the transplant center so that they can monitor your blood to make sure that they are matching you for the right type of organ that's going to match up with you. And your blood, the proteins in your blood can change over time, which is why your blood has to be so closely monitored before you get transplanted. And then, luckily, you get transplanted. Once you get transplanted, again, there's lots of follow-up. Here at the George Washington Transplant Institute, we see our patients twice a week for the first month after transplantation, and then once a week for the next month, and then monthly. There always needs to be good follow-up after transplantation. The transplant evaluation. Why do we do things the way that we do? Well, it's very important that you meet with the team, and the team is pretty extensive in order to be listed for transplant. You meet with the transplant surgeon. I'm a transplant surgeon, but there's other doctors you meet with. You meet with the transplant nephrologist. Now, most people that are on dialysis already have a nephrologist, but you need to meet with the transplant nephrologist, kidney doctor, when you come in for evaluation. You also meet with a social worker, a dietitian, a financial counselor, All of these people are very important to making sure that you are adequately prepared to be listed for transplantation. There's lots of education that goes on. If you have a live donor, that person needs to start their workup in order for them to be ready to give you a transplant. So as I just stated, who's on that team? Surgeon, nephrologist, a nurse coordinator, a financial coordinator, a social worker, a dietitian, a post-transplant nurse who's going to follow you after transplant, and then your team of doctors and dialysis nurses that, if you're on dialysis, that are currently taking care of you. All of these people have to come together to determine if you're going to be a good candidate for transplantation. This is just going through what are the roles that everybody plays. And again, it's the surgeon that performs the surgery. The nephrologist actually is involved with, are your dialysis labs where they should be? In other words, everybody who's on dialysis, you get labs every time you go to dialysis. If you're on peritoneal dialysis, every month you're getting the labs. The nephrologist is going to follow up with your dialysis team to determine if your labs are where they need to be. Your coordinator really becomes, it's like a concierge. That person really marches you through everything that's going to happen before transplantation. Your financial coordinator makes sure that your insurance is up to date. This is important not just because you need to have insurance to come into the hospital and get the transplant, but because you need to have good coverage, because after transplantation, you need to take lots of medicine, and if you don't have adequate coverage, you could be billed for some of these very expensive medications. So the financial coordinator winds up becoming very important. The social workers are also very important because there's all sorts of things that people in the transplant world wind up needing that they don't know or predict that they're going to need before they undergo transplantation. They could need a period of rehabilitation. You could need a nurse to come out to your home. Social workers can help with living arrangements. Actually, there are monies available from organizations to help people depending on their financial straits with expenses, particularly donors, the types of people that might want to donate to you. They might have to take off from work for a while. The social worker can help them identify organizations that will help with their expenses. Post-transplant nurse is very important, and the post-transplant nurse becomes the person that is your quarterback after transplantation. The dietitian, it says here, nutrition and weight loss. Well, this can be of the utmost importance because if you're overweight, if you're over our cutoff for weight, you're not even going to qualify to get a transplant. And then if you gain weight after transplant, you could have problems, including losing the transplant. So the dietitian becomes very, very important. And then again, like I said, the post-transplant nurse is your quarterback after the operation. And your current dialysis team is important as well because they really are the people that tell us what's going on with you on dialysis. And that's important in determining if people are going to be the right sort of candidates for transplant. There are a few things that rule people out in being transplant recipients, but we do rule people out often. What we like to do is we like to actually bring them in and evaluate them ourselves rather than have people think they're ruled out because of cancer or smoking or drugs. Most problems like that we can work out unless they are very severe. So cancer is only a problem if it's been recent, within usually the last year. Otherwise, it should be okay. All of the health issues, we would rather get the studies done in our center and determine if you have a health issue like a heart problem or whatnot, that we would then say you're not a good candidate. Most times, if there's something that can be manipulated or changed, or you can change on your own over time, we will defer a patient. So if a patient has some kind of a lung issue and they're a heavy smoker, we want them to stop smoking. We won't deny them. We'll defer them, let them stop smoking, let their health improve, get another lung exam, and go from there. So we try to bend over backwards to give patients the benefit of the doubt if they have a problem that might not make them the best surgical candidate at the time. Now, what happens when you're on the list? Well, you still need follow-up. We bring patients in every year to follow them up to make sure that they continue to be in good shape in order to receive a transplant. Because what we don't want to happen is for you to get an offer and everything's set and ready to go, and you come in and then we find out that you have a medical problem that would preclude you from getting a transplant. Around the country, the wait times vary. I can tell you, in the Washington, D.C. area, the wait for a kidney, if you have to wait for a deceased donor, is upwards of 5 years. So from the time you get listed, you may have to wait 5 years or more to get a transplant. Now, it doesn't mean that you will have to wait that long, because we have patients that we list and we transplant right away. So you always need to be ready to go, but the average wait time can be that long. It varies across the country. Some areas of the country, like the South or the Midwest, you can get transplanted quicker, whereas the Northeast and the Northwest are the places that are hardest to get transplanted. I would like you guys to understand that there is a new allocation system, and this new allocation system actually gives people points for the amount of time that they are on dialysis. So let's say you are on dialysis for 6 years, and then you finally go in and get evaluated and put on the transplant list. Your wait time is now 6 years instead of starting from 0. And that has been a huge benefit to patients because it gets them transplanted a lot quicker. So the new allocation system benefits people that have been on dialysis for a while, and it also benefits people that are what we call in the transplant world are sensitized. To be sensitized means that you have built up antibodies against other human antigens. When you've built up enough of these antibodies, you then have a harder time being matched up with someone to be a kidney donor. Because of that, the transplant community has now given an advantage to those patients. So you get an advantage for being sensitized, and you get wait time for dialysis time. These changes to the allocation system has made it where certain groups of patients are now transplanted at a much, much greater rate than they used to be, particularly patients in areas where the access to transplant had not been good before, like the inner cities and the rural areas. Lots of our African American and Hispanic patients have benefited from this new system. So if you look at what the new transplant system, they call it KAS, what it has done is it's improved the matching, and the better matched you are, the better the outcomes. It's made the system more fair, and it has made people who have certain blood types better able to receive transplants. In other words, if you look at everyone in this country by blood type, the most common blood type in this country is going to be blood type O, followed by blood type A, followed by blood type B. So if you're a blood type B person and you're waiting on a transplant, a donor is much more likely to be blood type O or blood type A. Therefore, if you're blood type B, you have to wait longer for a transplant. If you are a minority patient, meaning that you're Asian American or Hispanic American or African American, the percentage of blood type Bs in those groups of patients is higher. And that's one of the reasons why minority patients used to wait longer for transplant. This new rule change has made it easier for them to get transplants. The United Network of Organ Sharing, UNOS, is an organization that really manages the contract for organ transplantation in this country. CMS, which is a government agency, is in charge of this contract. But UNOS, United Network of Organ Sharing, which is a quasi-governmental agency, semi-private, semi-government, actually makes sure that we have equal and equitable transplant outcomes and opportunity for all patients in this country. So the transplant team has to closely monitor you after transplant. It's very, very important that patients that get transplanted are followed up by their transplant team. One of the things that we do on all of our transplant patients is we get a biopsy after transplant in order to make sure that there's no rejection and that the kidney is in pristine condition. A person that gets a kidney transplant and it functions well for a long time has just added on at least a decade, but moreover, probably more than 1 decade of life expectancy in comparison to staying on dialysis. Let's go back through the questions that I asked you at the top so that you could understand why I asked these questions and why it's important to be mindful of these problems. So remember, I said, what's the most common cause of kidney disease? Well, like I said, it's diabetes followed by high blood pressure. Usually it's a combination of diabetes and high blood pressure. Well, I will also tell you that after transplant, the most common problems that cause problems for the transplanted kidney relate to diabetes and high blood pressure. Taking care of these problems is of the utmost importance because it being high blood pressure and diabetes, these problems will eat up a transplanted kidney within years of transplantation. So if you don't or haven't learned a lesson prior to transplant, if these are the reasons why you had kidney disease, then you must learn the lesson after transplant. Your blood sugars need to be in the normal range, and your blood pressure needs to be in the normal range. What is normal? Well, a hemoglobin A1C less than 7 needs to be the norm for a transplanted patient. That's a norm. That's pretty much normal blood sugars throughout the day. A normal blood sugar reading is going to be around 120 or less. These are the things that are important to maintain your health after transplantation. High blood pressure. I tell people all the time, it doesn't matter that you're taking high blood pressure medication. What matters is is your high blood pressure under control? What's under control? Under control means the top number needs to be less than 140, and the bottom number needs to be less than 80. Many patients think, oh, my top number is okay, so if my bottom number is high, it doesn't matter. No, 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 no. Both the top number need to be good and the bottom number needs to be good. And if it's medication that's keeping your blood pressure under control, you need to take that medication. And if you're taking medication and your blood pressure is still not under control, you need to change your medication or increase your medication. These things are very, very important. So, like I said, diabetes is the #1 cause of kidney disease in the country. What contributes the greatest possibility of developing kidney disease? Like I said earlier, epigenetics. What are epigenetics? Epigenetics really has to do with your behavior. You know, people grow up eating certain sort of foods, usually comfort foods are associated with culture, right? In the South, I'm originally from the South, people eat lots of fried foods. People tend to use lots of salt when seasoning their meat. They eat lots of pork. All of these things, fried foods, added salt, pork, lots of red meat, all of these things will cause your body to hold on to more salt. Preservatives also work in this way. And when you eat lots of salt, when you eat lots of red meat, and you're not getting adequate exercise, you, #1, will gain weight. But #2, you're going to expand your fluid volume, your blood volume. As you expand your blood volume, you are going to push up your blood pressure. As you push up your blood vessel, you increase the risk to vascular disease, peripheral vascular disease, cardiovascular disease, and cerebral vascular disease. That means that you increase the risk that you're going to have a heart attack. You increase the risk that you're going to have a stroke. You increase the risk that you're going to have problems with the vessels that go to your legs. Once you have vascular disease, you have now shortened your life appreciably just because you have vascular disease. It's imperative that people realize that their diet is inextricably linked to their health. It can change, meaning your diet can change, but it takes a concerted effort. You can have some of the same sort of tastes or similar sorts of foods that are healthy, but it takes someone being committed to changing their diet, changing their habits, increasing their exercise, increasing the intake of water. All these things directly impact your health. The water thing is a big deal because, first of all, if you're a dialysis patient, they limit the amount of water that you can drink. But as a doctor, I will tell you that nothing is healthier for you than taking in lots of water every day because, #1, it helps to distend the stomach, and you tend to eat less food, particularly less unhealthy food. #2, it helps to flush the kidneys, which helps to flush out toxins in the body, which ultimately redound to overall health. You know, the problem with people with kidney disease is that these toxins are building up in the body, and these toxins affect all of the organs of the body. Let me repeat that. The toxins that build up because your kidneys are not functioning well affect all of the organs of the body: the brain, the heart, the lungs, the liver, the adrenal gland, so on and so forth. All of your organs are affected by the fact that your blood glucose runs high or your blood pressure is high. That's why there's a big difference in the types of patients that I see for transplantation. I see patients that are in one of two groups. The first group, which is the majority of the patients that I see, they have a systemic disease. Diabetes is a systemic disease, meaning it's all over your body. You don't have diabetes in one part of your body. All of your cells of your body are affected. High blood pressure. High blood pressure affects every blood vessel in your body. It's a systemic disease. However, you could have a kidney-specific disease. Like an example would be polycystic kidney disease. Those patients have a kidney-specific problem. Those patients tend to be much healthier than the systemic disease patients. As humans, as Americans, people in the world, we don't want systemic diseases. You shouldn't want a systemic disease. Systemic diseases cause patients to have much shorter lifespans. It's not just about kidney disease, it's about overall health. But I will tell you, if you take a person that has a systemic disease and then you give them kidney disease, you have vastly, vastly accelerated their demise. In other words, the hypertensive patient that now has kidney disease has just shortened their lives by decades once they start dialysis. I'm not saying this to scare anyone. I just want you to understand how linked all of these things are. There's no mystery why people develop kidney disease. Oftentimes my patients tell me, oh, they didn't know why I got kidney disease. That is very unusual. We can figure it out, and it's usually a combination of diabetes, high blood pressure, and obesity. So the answer to this question, of course, was epigenetics. Epigenetics has everything to do with behavior, period. What is the most effective way to control high blood pressure? The most effective way to control blood pressure is going to be simply to lose weight. Now, of course, diet is a big part of that, but if you see a patient in your clinic, in my clinic, as I do, and their blood pressure is high, if that patient loses 20 pounds, their blood pressure will be lower. I'm not saying it's going to be normal, but you will lower your blood pressure by losing 10, 15, 20 pounds. So the most effective way to lower your blood pressure is to lose weight. The most effective way to lose weight is to change your diet, right? So exercise and diet are going to be the most important things to decrease your blood pressure and decrease your risk of kidney. So one of the things I'm always doing with my patients is making them understand how important their diet and important their exercise is to their overall health. The other thing that exercise and diet will do, if you're diabetic or pre-diabetic, is it could make the diabetes go away. Diabetes can be reversible. Most people have type 2 diabetes. Type 2 diabetes exists because people are overweight. You lose weight, you could not be a diabetic. So, once again, this all goes back to your own behavior. This influences what proteins are expressed in the body. This is what epigenetics is all about. The other thing that exercise does for people that are diabetic is it increases the action of metabolically active tissues. What are metabolically active tissues? Well, your muscles, and your organs. So your heart is metabolically active, your liver, your lungs, your brain, but mostly your muscles. So when you increase your activity by exercising, by walking, running, spinning, whatever, you are increasing the activity of the metabolically active tissues, which cause your insulin to work better. And when your insulin works better, you're less likely to be diabetic. Adipose tissue, fatty tissue, is not that metabolically active. It kind of sits around, which is why it has such an influence on how well the insulin in the body works. And when the insulin in your body doesn't work well, you become diabetic. Now that's much different than being what's called a type 1 diabetic. These people are born without good insulin production. But the majority of people in this country are not type 1 diabetics. 98% of diabetics in this country are type 2 diabetics, which means they're overweight for the most part. Or you could be a normal weight and still be a diabetic, still be a type 2 diabetic, and it means you don't move around enough. You don't get enough exercise. What is the one most common cause of self-induced kidney disease? Well, like I alluded to earlier, it's nonsteroidals. I'm always surprised at how many people are taking a lot of ibuprofen or Advil or over-the-counter medicines for pain. This hurts the kidneys if you're taking it numerous times a day for many days in a row. The message needs to get out there that people need to be mindful of nonsteroidals, because when taken in high dosages for a long period of time, they cause kidney disease. What's the most common type of diabetes? I just told you, type 2, right? And again, we went through everything about why diet and exercise is such a big problem there. I want to be able to open things to questions because I really hope people have questions for me. But I wanted to tie in, the fabric of what is transplantation. Well, transplantation is just a continuum of what should be good health. And the patients that have the best outcomes after transplant have the best health. And the way to have the best health is to be mindful of how to take better care of your body. And I hope that's the message that comes across today. But please, I want to open this to questions.
So one of the questions that came in from the chat are previously transplanted people sensitized, and does this mean that they would go to the top of the transplant list?
That is a very good question. And the answer to that is yes, previously transplanted patients have a higher chance of being sensitized. And if you are very sensitized, because there's a gradient between being sensitized and being highly sensitized. If you're very highly sensitized, then yes, you do go to the top of the list. The highest group would be a group that's called 99 to 100%. That means that you would have antibodies to only almost 100% of people in the United States. You are programmed into the system to go to the top of the list, and those patients can be transplanted when we find a match, sometimes very quickly. Now, not every prior transplant patient is going to be sensitized. You could have had a transplant before, and if you didn't have a rejection and the transplant lasted a long time and there weren't any problems, you probably are not sensitized. So it depends on the patient, but in general, transplanted patients are more likely to be sensitized, but also women that have had babies, anyone that have had blood transfusions, these are the groups of patients that are more likely to be sensitized. Patients in any one of those groups, if they're sensitized, get an advantage for transplantation. Great question.
Another question that came in through the chat is, why isn't the requirement to have DM and HTN under control before their first transplant, or that they are not put on the list until it is controlled? Seems that there is a risk of failure when others who adhere to guidance may be pushed further down the list.
Wow, another very good question. And I will tell you that actually we do make an emphasis to get patients to understand that these problems must be better controlled before they're put on the list. So most transplant centers actually have a stipulation that patients have to have their blood pressure and their diabetes under control. Now, there's still a gradient there, right? I'll give you an example. If your hemoglobin A1C, which is a measure of how well your diabetes is controlled, if your hemoglobin A1C is very high, and very high in our parlance would mean a number like 9 or 10 or higher, well then to us, that means you are not doing a good job at all of managing your diabetes, and you would not get listed. Now, it could be 8 or 7.5. We would want it better than that, but you would get listed, although we would want you to better try to manage your diabetes. Same thing with high blood pressure. If your blood pressure is consistently very, very high, then you're not going to get listed. It can still be a little high, and you're on medicines, maybe on dialysis, and we will list you, but we will follow you. Because remember, just listing is not the end of the road. We follow these patients, and sometimes we will list a person by giving them the benefit of the doubt, but then follow them up, and if the behaviors have not changed and the compliance is not better, we will then delist them. But the spirit of the question is a very good point, that this is a very precious commodity, organ transplantation, and we don't want to quote unquote waste an organ giving them to people that are not going to be compliant, because compliance with medication and care is very important to good outcomes. So I get the spirit of that question, but I can tell you most transplant centers also are going to try very, very hard to keep patients that are not compliant with their care off the transplant list. Great question.
Another question is, when you talk about NSAIDs, are you including aspirin?
Very good question. And in general, I am not including aspirin. Although aspirin is in that class, the other effects of aspirin are to the benefit of the patient that requires it. So because you get so much more of a benefit with the antiplatelet action of aspirin when you're talking about heart disease and vascular disease, the fact that aspirin in that class of nonsteroidals also negatively impacts the blood flow to the kidneys, we don't have the same prohibition with aspirin that we do with some of these other medicines, particularly because aspirin doesn't have the same degree of effect on blood flow to the kidney. Another great question. You guys have great questions.
Another question is, what do you see as the best way dialysis centers can support patients who are on the wait list for many years?
Yeah, good point. And, you know, this is one of the areas that we, in my center, work very closely with dialysis centers. My bias is that I think patients in general need better education. I find that the better educated the patient is, the better their compliance, the better their outcomes. So I think in the support that a dialysis center gives to their patients, they need to be constantly educating these patients about their behavior, their compliance, their health, in order for the patients to do what needs to be done. let me give you an example. Since I see patients that are typically coming to me from dialysis centers, I can tell you, because we go to these centers a lot, that the patients that have the better outcomes and that are more likely to be quickly listed for transplant come from centers that do a better job in educating their patients. Well, how do they do that? Well, they do that with making sure that they have coordinators that go through in excruciating detail what a good dialysis patient is. A good dialysis patient does certain things well, right? Every dialysis center goes over the labs that the patient has. And what, other than just giving you that report, the center should be telling you why your labs are not where they need to be. Every dialysis center weighs their patients between treatments. They should be going over why, if your weight is not appropriate, why that's a problem. Every dialysis center keeps all these records, and we're privy to those records when we are trying to determine if you're going to be a good candidate. The dialysis center, and we do this as well, needs to educate the patient that the transplant center is going to understand that the problems that the patient's having on dialysis, the problems that the social workers tell the transplant center, the problems that the dietitians tell the transplant centers are going to impact if that patient gets listed. So I think it's all about education. Now, I will also put the onus on the patient because, once again, the more active the patient, the less passive the patient, the more compliant the patient, the better health the patient is in. So, yes, the dialysis centers need to do a better job. Many of them are already there. But the patients have so many resources now that are in the center, but also online, that they can access to make themselves healthier. So I put the onus not just on the centers, but also on the patient. But yet again, another great question.
Another question is, if I'm training every day, how much is too much protein? I've been waiting 7 years for a transplant.
Yes, this is a common question that comes up from my patients that are trying to do the right thing. And what I would say is, if you have kidney disease, which obviously this person does, then really you shouldn't be taking in more than, say, 20 or 24 grams of protein a day, because then your body is not going to be able to clear it. If you have a healthy kidneys that are functioning well, like post-transplant, then it is okay to take a little bit more in than that. But I would say someone that's in kidney failure, that's on dialysis, really shouldn't be taking in more than that. Now, I have had, and I will tell you, in the course of my career, I've dealt with people that are marathon runners and that are super-duper highly trained athletes, including professional athletes. And these people that are so well trained and are utilizing their muscles to such a degree, sometimes we can make a caveat and allow them a little bit more than that. But really, for the average patient, even the average patient that's working out regularly, they shouldn't be taking more than 20 grams of protein a day of supplements. Now, I'm talking supplements. The additional protein that you would get in a normal diet, that's okay. But I'm talking about 20 grams in supplement to a regular diet, a regular renal diet in this patient's case. Thank you. Great question.
Another question is, in the past, I have been trained that a patient should not have excess fluid on them before transplant. I have had a couple patients transplanted this year, and they have told me they were given fluid because they did not have enough fluid on them, so were not dehydrated.
Yeah, no, occasionally patients come in for transplant and they are a little dehydrated, particularly if they would have received dialysis right before. I just did a transplant last night, and the patient I transplanted had just come from dialysis. That can happen sometimes, and sometimes you have to give extra fluid. But on measure, most patients are going to have plenty of fluid on board, and it's not a problem. Not having enough fluid is not going to stop you from getting your transplant. What is more important is if you haven't had dialysis and you are a dialysis patient, when you come in for transplant, one of the things we need to make sure is that your potassium is not too high, because the anesthesiologist will not be able to put you to sleep if your potassium is too high. So that's something we need to check acutely when a patient comes in for transplantation. The fluid status we can deal with quickly. Low fluid is never a problem. High fluid can be a problem because we may have to dialyze you in the hospital before transplant. Another great question. This is a great group.
Another question is, how many years to life are gained after a kidney transplant if a patient follows risk reductions of failure?
So once you get a transplant, the rest of your life, there is a risk for failure. So I've seen patients that have had transplants many, many years, and then unfortunately they fail because of some remote complication. I've had patients that have had transplants for 20 years or 30 years and go on a vacation to a third world country and get a parasitic infection, and it affects their transplants. So you're always at risk of a complication that can hurt your kidney. Now, of course, you're not like in a bubble after transplantation. So we want people to live normal lives, but you need to be mindful that you need to stay in areas that are clean and not put yourself at undue risk. However, I will tell you that as far as time-wise, the highest risk, as far as what we are concerned about in transplant, is going to be within the first 3 months. Because the first 3 months after transplantation, that's when you're at the highest risk of rejection, and that's when you're at the highest risk of infection, because some of these strong medications that we give you in the hospital are still having an effect even 2 to 3 months after transplant. After about 3 months, if your kidney function is normal and you're tolerating the medications well and you're compliant, you really are out of the woods, so to speak, and you just need good, regular follow-up with your doctors. Great question.
Well, Dr. Melancon, thank you so much for such a great presentation. Great information both on ways to slow down kidney disease as well as the path to treatment. Just a lot of information there. I have tons of notes. Thank you again so much for sharing your thoughts with us today.
Oh, no problem. This is my pleasure. Any opportunity that I can have to inform the public, I love to do that. So thank you for having me, and there were many, many great questions. Thank you, guys.
We thank you again, and for those on the line, we will be, it has been recorded and we'll be posting it because I know a lot of people will want to listen to this information again because it had a lot of good stuff in it. So thank you again, and I want to thank everyone who participated today, and please fill out the feedback form that will give us information, as well as we hope to see you on our next webinar, which will be about options as well, but looking at more looking at it from dialysis as opposed to transplant, and you'll hear from a doctor and a patient story. So we hope to see you next month as well. Again, thank you everyone for participating today. And we hope to see you next month.
Thank you.